Hello, everyone, and welcome to today's webinar from the Society for Implementation Science in Nutrition. My name is Isabelle Michaud-Letourneau, and I'm an independent consultant working with SISN on several projects, including the Implementation Science Initiative in Kenya and Uganda, which is the focus of today's webinar. Just a little bit of housekeeping before we get started. If you have any questions during the presentations, I will ask you please to type them into the question box in your GoToWebinar control panel. You may send them anytime during the presentation, and we'll keep them for the Q&A session at the end of the presentation. I'll pause as many questions as possible to Tua and Brian, our speakers, as the time allows. If you experience any technical difficulties, please also type your questions in the question box, and our staff will help to address these. We're also active on Twitter and encourage you to chat and engage with us through our Twitter hashtag, which will appear in the chat box. And finally, a recording of the webinar will be made available after the sessions. So before I introduce our first speaker, I'd like to set the stage by sharing with you a little bit of background about this initiative. The Implementation Science Initiative in Kenya and Uganda is in fact the first initiative of SISN to try to operationalize its framework in country and apply the principles of implementation science. I have the great pleasure of being the senior technical lead for this initiative, and I work closely with David Peltier, the past president of SISN, who had a clear vision about this initiative. We're also fortunate to work with the 3IE, which is the International Initiative for Impact Evaluation, thanks to a grant from the Bill and Melinda Gates Foundation to support this initiative. So quickly, I will present the main objective of this initiative and the components, and then we'll move quickly also to the experience in Uganda and Kenya to hear more how it's happening and go with some questions. So there are 4 objectives to this initiative. The first one being to strengthen capacity for applying implementation science at the country level. The second one is to also strengthen the interaction and the knowledge exchange among various key stakeholders, being policy, program, and research. And we, with these 2 objectives, we also want to strengthen the implementation of iron-folic acid supplementation programs. So a few words why this programs has been selected. It's because IFAS programs have been implemented in many countries for many years. And at scale, there are often challenges in terms of the implementation of it. So we have decided to focus on this and have major learning from this experience. And with these 3 objectives, there is an additional one that I'll talk a little bit later, but it's to increase the knowledge about how to apply implementation science. And so to do this, we have a structure of SISN and 3IE being the support team. And we interact with the national core team that you will hear today. You will hear their program project manager, Tuaha and Brian. And they interact with a large diversity of actors in countries. So all those different groups and actors interact sometimes directly and indirectly to carry out this. And in this initiative, there are 6 components that I'm going to briefly mention because those were kind of developed to address some of the main challenges. Some of you probably know the analogy of the blind man and the elephant. So there is often in countries a lack of a shared understanding. So the man who touched the side of the elephant will say, well, an elephant, it's a wall. And the man who touched the tail will say, an elephant is a rope. And so we all work in different places in systems, and we have a different understanding. And so the strategy is really to work with a diversity of stakeholder part of the core team to build the collective tacit knowledge, and the team will discuss how it's happening in their country. The second one is what we call like the bottleneck assessment and inventory. Because when we're implementing programs, and I'm sure it will resonate with many of you working in other programs, there are multiple barriers in bottleneck experience during implementation at all different levels. And so what the team have done is to do a comprehensive bottleneck assessment and to document and try to address those bottlenecks in an ongoing manner. And my role is to work with them to try to develop tools and also have access to different innovation that may have been tried in other places. And so we have developed this as a comprehensive and a systematic approach for this initiative. The third one is knowledge brokering that some of you may have heard. Knowledge brokers are in different organizations. And for this initiative, we know that there is a lot of existing knowledge that it's not always accessible for people working at the program level. There is no way implementers can know all the research that is being done, and researchers are often not interacting much with them. So with this core team as well, they play a role of a knowledge brokering team that play different roles. You have 5 main domains of knowledge brokering here that have been developed by other researchers, and we're trying to use this. And then there is the component of implementation research, because there are sometimes like knowledge gaps and questions that program managers would like to answer. And so we have developed pieces of research that the team will also talk about to try to identify gaps or to address the gaps identified, to have the implementation priorities, or try just different solutions and see how it goes, but through having like a more formal implementation research. There is also the implementation science network that is being created. That's all at this stage right now, but because people in the field are a little sparse, and we're trying just to build an implementation science in country building of existing networks as well. And finally, there is the documentation of this that try really to answer the fourth objective, that is really trying to see how we can increase capacity in country. And so I'm learning and I'm following the project coordinator and really doing some exercise of reflective practice. When there are some challenges, we try to develop tools, and it's really like my role to try to support and document this whole experience. And so those 6 components, in fact, if you're familiar with one of this framework developed by SISN, it's really trying to operationalize this. So you have the implementation science in the middle, and around like different type of knowledge that we're trying to use. And you have also like the use of those different strategies for knowledge brokering and capacity building. So that's really what we have tried to do this. So without further ado, I will introduce you the next speaker, who is Twaha. Twaha is a nutritionist with a postgraduate degree in public health and a bachelor degree in human nutrition and dietetics from the International Health Science University and Kiabogo University, respectively. Twaha is currently the project coordinator for this initiative that is implemented by URC USAID, our East Central project. Prior to this, he was a program manager, specialist for USAID Uganda, funded Strengthening Uganda System for Treating AIDS Nationally, that is the SUSTAIN project. Through his work experience, Twaha has built and successfully managed relationships with ministries of health and other host government counterparts, implementing partners and their various stakeholders. He has special interest and experience in research in monitoring and evaluation in the field of nutrition and health. And so we're very fortunate to have Twaha in the team with us. So Twaha, the floor is yours.
Thank you very much for the opportunity. And Isabel, thank you very much for the introduction. The Implementation Science Initiative is implemented under the Rights EC project, like Isabel has alluded to. And in the East Central region, the project is implemented in 12 districts. And for this particular initiative, we selected 2 districts, one being a rural district, that is Buyende district, and then the other being Iganga, which is a peri-urban district. Specifically, the selection criteria was based on their performance in terms of key antenatal indicators, majorly focusing on iron-folic acid uptake by the pregnant women, specifically during the first antenatal visit, and most of these 2 districts were not meeting the project target. Right away, like Isabel has alluded to, in terms of sharing our experience, we have been able to establish a national core team. And the national core team was established in collaboration with the Ministry of Health, because one of the key objectives, like you've already seen, is for us to build a core team at the national level that will be able to spearhead this entire implementation science in nutrition, also being a very new area. So that means some of the core team members that we selected were the line ministries, that is particularly the Ministry of Health, and then the Ministry of Local Government. And the Ministry of Local Government, this is because because of the districts being under the Ministry of Local Government, and they directly report to that ministry. Then, of course, we also have the Office of the Prime Minister, which is currently in Uganda. It coordinates the Uganda Nutrition Action Plan, and therefore they are in charge of looking at the multi-sectoral nature of some nutrition interventions, and one of them being iron-folic acid supplementation. Therefore, their presence in the group is very key in terms of pushing the agenda forward, but also in terms of advocacy and being able to scale up these learnings that we'll be documenting. Then, of course, UNICEF in Uganda also is one of our bilateral organizations that supports iron-folic acid supplementation in very many districts in the country. So we also were able, working with the ministry, to be able to bring them on board. The other organizations is the HAD project that is implemented by Infectious Disease Institute, and this one is because of their vast experience in using implementation science approaches, though they're implementing more in urban central Kampala and the other areas. Then, of course, the research institutions or the academic institutions, and here we are working with Makerere University, particularly the School of Public Health, and it's because of their key role in terms of experience in research, but also in terms of being able to actually act as knowledge brokers as well. So to officiate all this entire national core team program, the Ministry of Health officially wrote out to these organizations, and they were able to nominate individuals to really always be part of the group and to be able to support the entire initiative. Of course, in terms of ensuring that the team is functional, we've managed to see that they actively participate in the bottleneck assessment, as we shall be discussing briefly. And then, of course, the team was also able to sit down and actually agree and discuss their own scope in terms of supporting this implementation science initiative. So the core team already understands what their roles and responsibilities are, and how this is entirely a shared partnership, as opposed to just having the usual meetings that we see happening. The other key area that we've looked at, and which is a key component for the implementation science initiative, is the bottleneck assessment. One of the initial activities that we conducted in the beginning of this work was to conduct a national level or an initial bottleneck assessment, which looked at, first of all, included some of the core team members, but also the district level, and then the health facility members, to be able to really assess the bottlenecks and the challenges that are faced in terms of iron-folic acid supplementation. Some of the pre-workshop activities, we conducted an assessment using the data tool from Spring, and then, of course, because the program assessment guide was used to really help us to develop key materials that were used during the workshop. So we're able to modify and identify which key areas of the program assessment guide we would use to actually be able to map out the systems, but also be able to identify the bottlenecks at the health facility level, at district level, and at national level. And the workshop was entirely participatory, so people were able to work in different groups, looking at the supply chain side, and then, of course, looking at the service delivery point. And briefly, we'll see the different mapping systems. So one of the things that we did during the workshop was to really map out the systems. And when you look at the service delivery system, with support and working with the health workers and then the academia and the other team members that were able to participate in the workshop, we mapped out the service delivery flow at a health facility level. When the pregnant woman comes into a facility, what are the areas or the steps that they go through to be able to receive services? And this was also taken to the next level after the Bottleneck assessment workshop. We were able to do a district level validation and national level validation. And to our the interesting findings were that this was actually the same flow that we were able to discover when we went for the district level validation. So the district level validation actually gave us all the same findings as we had initially seen at the national level. So we have a couple of steps here. The waiting area is where the health workers provide health education for the mothers and do a little bit of triaging in terms of taking blood pressure, taking weight, and all the other services that offer that triage. And then from that, they are sent to the laboratory, where most of our antenatal clinics do actually HIV testing and syphilis testing. Surprisingly, or one of the key gaps was really that most of our laboratories here in antenatal do not actually do hemoglobin or HB testing. So that was one of the gaps that we were able to identify. Then, of course, from that, they are sent for physical examination, where they do the palpation, and then from that, they are counseled. And here, during the counseling, it's usually targeted. It's not group counseling, and it's not for every woman that comes for antenatal, but it's majorly those that are identified from the triaging point and from the physical examination. For example, if they find a woman is anemic, then that's when they provide one-on-one counseling. Or if she's been identified with she's HIV positive, then they provide the one-on-one counseling. Then from that, the dispensing, and this is where they provide the iron-folic acid. And most of the services, they do not have a separate dispensary, but it's within antenatal, so the woman is able to get all these services under one roof. And then from that, they are given appointment return dates, which they call follow-up as health workers. Then from the supply chain side, there is one procurement planning meeting every year. And here the lower health facilities, which are the health center 2s and the health center 3s, determine their kit, their drug kit that will take them throughout the financial year. And then for the higher service delivery centers like the health center 4s and hospitals, they're also able to quantify their needs for the year so that it can be included into the financial year's budget. And this is where the entire supplies for the year will be determined. Surprisingly, one of the things is that iron-folic acid is also among these commodities that are planned for during this cycle. And once you've determined how much quantity, in most cases, it is not changed until the end of the next financial year. So the bit about for the upper health facilities, they have a leeway to do the ordering during the different quarters or cycles because they have a little bit of a higher budget and they can easily change. But for the lower facilities, once they're predetermined during the procurement plan, then in the next cycles, it's only their kits that are delivered. So if they made any over projections or under projections, it means they are affected throughout the year. And then from that, the drugs or the supplies are delivered from the national medical stores or the warehouses, because we have different warehouses, but national medical stores being the main one. And then, of course, they are delivered to the district and health facilities where they're supposed to be used and accounted for accordingly, and report to the Ministry of Health and the national medical stores. So that was the mapping system for the service delivery and also the supply chain. Some of the iron-folic acid supplementation bottlenecks that were identified from the service delivery point, you can see we have a number of them, among which includes regular stockouts and coordinated health education, and then the poor access, and then the supply chain also has a number of them that were identified from the discussions that we had with the different teams. And these were ranked using a pairwise ranking. And so from the team, as they were discussing, there were 3 major bottlenecks that were identified and ranked highly. from the pairwise ranking results. And this was the uncoordinated health education, the regular stockouts of iron folic acid, and then lack of male involvement in supporting pregnant women to access antenatal services. And these are the bottlenecks that the Implementation Science Initiative moving forward has been able to discuss. And one of the things that we realized is that these three bottlenecks were actually affecting the three systems of health services, and that is the service delivery system. And we look at the service delivery system in terms of the uncoordinated health education, realize that it is more of a health facility-based issue that can be addressed by organizing the systems in the health facility. And then the supply chain, we looked at the issue of the regular stockouts and its underlying causes, like the issues of not improper quantifications, and also the lack of teamwork in the teams of the service delivery and supply chain, and then the user systems where the teams were able to identify and say one of the things that is affecting antenatal services, and particularly iron folic acid, is the fact that the male partners are not more involved. And from the discussions and URC and the researchers and SISN and all the other teams were able to agree and say, since URC is already supporting some of these initiatives in the region, we should be able to use quality improvement approaches and implementation science to actually improve iron folic acid, addressing all these three systemic barriers or bottlenecks. So moving forward, in terms of our research, we have zeroed on using quality improvement, and it's because URC really has vast experience in implementing quality improvement, not only in Uganda but other countries. And Uganda it has a very nice national quality improvement framework that actually ensures that there is quality clinical and non-clinical care, and of course compliance with standards and guidelines. So one of the things, so URC already under the Rights Project has also been able to support some of these districts, actually most of the districts, to institutionalize the quality improvement, but also really focusing on the use of the national QI policy and framework to actually cascade the entire structures of quality improvement to ensure the teams are available and functional, to ensure the capacity is built and all this. So from the discussions, this implementation science initiative actually can already be able to ride on what Rights EC has already supported at the health facilities in the districts of Buyende and Iganga, but this time round, focusing on iron folic acid supplementation, and particularly to address the barriers that we've looked at. That's the uncoordinated health education and the regular stockouts. Of course, the study objective and methodology, we are looking at how iron folic acid supplementation health education and drug quantification are being done, how the quality improvement interventions is being implemented, and then study its effects on how it can improve IFAS related outcomes, particularly in terms of uptake and probably in terms of addressing the stockouts, and in terms of also being able to see that the pregnant women can probably adhere more to the iron folic acid that is given to them. We are using an effectiveness implementation hybrid design. This is a relatively new design that actually helps you to study the processes and also be able to actually evaluate the outcomes. So one of the areas that we are focusing on, because this implementation science will have two studies, is to study the QI processes, the evaluation of the QI implementation at the facility level. Try to understand how quality improvement is currently being implemented at these facilities, and also try to look at how the PDSA cycles are working, to look at how we can adjust the iron folic acid delivery adjustments within the facilities, and then how we can tweak, because quality improvement is supposed to actually work within the systems to help realign the systems and without having to have too much investment, because we also look at the sustainability component of it. Then the second side of the study, because to be at the evaluation process, we have a comparison district, And we selected Busia because it's a bit, it borders Uganda and Kenya, but also because it's a bit far away from these two districts, we don't expect overlaps. So for the second study, we are going to use a quasi method, a quasi experimental method, and here we shall be comparing what is currently the standard QI health services that are being supported by RISE, and that is through the usual regular mentorships of the facilities and all that, and then compare it with the implementation districts, that is Uganda and BNA, where we've actually had to look at the quality, the QI standard health services, and then we also refocus them onto addressing iron-folic acid intervention. So we shall be able to, at the end of the day, or at the end of the study, to be able to compare the effectiveness of quality improvement in addressing the barriers that were identified from the bottleneck assessment. Briefly talk about the intervention and the PDSA cycle. Of course, one of the things that we are trying to, focus on is to actually study how long the changes will take for us to see improvement in terms of addressing the barriers, and this will help us using the quality improvement approach, particularly looking at the PDSA cycle. Now, the PDSA cycle is the framework that is used to help in terms of implementing quality improvement ideas and changes at the facility level. And in most cases, or by standard, it starts with planning, and under planning is where we have more of analyzing the problem. For example, if you go to the facilities, we'll be able to analyze why is the health education uncoordinated, what are the challenges in the systems, and what are the opportunities that are available. And then we're able to plan with the entire team, and this is where we'll be supporting the quality improvement teams or the work improvement teams at the facility level to actually be able to identify their challenges or their problems, and also come up with very key and simple solutions that they can do. Then from that, they'll be able to, we go to the do component where they carry out the plan, come up with an action plan, come up with who will do what, and then be able to plan on how to implement or study their objects. So under the implement, once they've implemented, they're able to actually look at the data, compare the data, look at how their progress is, so that they can be able to, at the end of the day, act. And under this act is where they will decide whether the changes have worked, so they should be able to scale them up, or they should be able to say, okay, this change has contributed a certain percentage, we need to improve here and there. Of course, like I already alluded to, URS is already doing this quality improvement work, so we'll just need to have to refocus it onto iron-folic acid, and particularly looking at these interventions in terms of ensuring that we support the health facilities to have these planning meetings to identify their challenges. We hope to have collaborative networks where the health workers and the health facilities will be learning from each other in terms of what is working where and what is not working where. And then, of course, the usual bi-monthly mentorships, and then the bi-weekly data management and reporting for them to really appreciate the progress of implementation.
Lastly, excuse me, Toa, thank you very much. We're going over, so I would ask you if you can just go to the lessons learned, because I think we want to leave sometimes. I see that questions are coming, so if you can go to your last slide with the lessons learned, people will hear that. Thank you very much.
Okay, lastly, in terms of the lessons learned, and which also documents our networks and all the other areas, we know that engaging stakeholders is very key for us for the members to own the system challenges and also be able to find solutions. And this is because one of the things that we realized is that during the bottleneck assessment or the bottleneck assessment workshop, members were able to identify the challenges, and actually health facility members were actually able to go back and actually even start implementing some of the potential solutions that were identified. Then, of course, the teamwork, it's one of also the key areas, because one of the things that was identified is the fact that the supply chain team is very independent from the service delivery team. That means that the midwives are actually, the only thing they do is ordering for the supplies, and sometimes to their surprise, they order and they tell them they're out of stock. So the kind of teamwork would also help in terms of actually identifying these, working and addressing these bottlenecks. Lastly, implementation science as a tool, we've just realized it's interesting for nutrition because it's a new area, And we realized that it's actually a very good approach for us to use to identify system issues or challenges and bottlenecks that we can actually address uh, and be able to improve service delivery. Thank you very much.
Thank you so much, Twaha, for such a great and illustrative presentation. I see that some questions are coming in, so please continue, and we won't see them. We will see them only at the end, but we were just accumulating them. So now it's my pleasure to go with our second speaker. We're going with Brian Njoroge. Brian is an operation research assistant with food science and nutrition background with 11 years of experience in public health, specifically in design, development, and implementation of donor-funded nutrition-specific and nutrition programs in Kenya. Brian was among the team that led the implementation of the first US government-funded HIV nutrition project in the 15 PEPFAR focus country, and that led to policy direction shift towards HIV nutrition programming for PEPFAR. Brian also participated in project design teams for two nutritional national projects that were funded and led implementation teams for these projects. Currently, he is the nutrition specialist for the multisectoral Kenya Nutrition and Health Program, the NHP Plus at FHI 360, a project that received multiple funding streams from USAID, including PEPFAR, Feed the Future, and Bureau of Food Security. Brian has made significant contribution to the body of knowledge of nutrition-specific and nutrition-sensitive programming in East Africa, and we are lucky to have him as the project coordinator for the Implementation Science Initiative on IFAS in Kenya. So now it's your turn, Brian. Thank you.
Thank you, Isabel, for the introduction. Good morning and good afternoon, depending on where you are joining us from. So I'm going to talk briefly about the work that we are doing on implementation science in Kenya. Just a quick introduction. The current activities, we are working with 3IE together with FHI partners, and we are layering these activities on the current USA Nutrition and Health Program Plus in Kenya. So this is part of the co-creation activities for the main project, and also speaks to a lot to the journey to self-reliance, being able to build evidence that the government here will be able to pick up and fund such initiatives. Thank you. So a quick outline. I'm going to talk about the core team briefly, highlight the bottleneck assessment, inventory of bottlenecks, and then also talk about our proposal, and then the lessons learned and the next steps. So when we started this activity, we did consult with the national government, and specifically Ministry of Health, Nutrition and Dietetics Unit, and through the leadership of the head of nutrition, we were able to be referred to the nutrition research technical working group. So in our country, under the nutrition fraternity, we have a number of technical working groups. So this was a newly formed technical working group that focuses predominantly on looking at national level research activities. Of course, this is because of the new structure of government, where we have national and we have counties. So the role of the national government is more focused on policy and research, and implementation happens within the 47 counties. NHP Plus works in 5 focus counties for this activity, and I'll be able to talk more about this. So when we were seconded to the core team, we were able to be, when we were seconded to the research working group, the head or the chair of the technical working group was able to form a subcommittee, which is the National Core Team for Implementation Science. The chair of this committee is actually part of the National Research Working Group, and she sits within the Kenya Medical Research Institute. So the composition of this team, we have participation from the Nutrition Dietetics Unit, the deputy head, and the micronutrient program officer. We also are fortunate to have the neonatal child and adolescent health unit, which is also a unit within the Ministry of Health. We have the Kenya Medical Research Institute. We have Nutrition International as an implementing partner, and we also have FHI partners who are currently implementing the activity. So for the bottleneck assessment, just like Uganda, we were able to do some adaptation to the program assessment guide. And in our case, we decided to walk through the 7 modules so that we were able to come up with the bottlenecks. Now, the key thing for the workshop was really the identification of participants. And because we have 2 levels of government, we had to do a mix and match with participation from the national level, as well as focusing on getting county health management teams, as well as the implementers at sub-county and health facility, and a bit of community health extension workers who are nurses. So this is just a summary of the participation in the bottleneck assessment. So we did get very good participation and also good feedback, and in terms of being able to receive the correct audience. So just a quick overview of the delivery system in Kenya, just because of it might be very different from what we see in other countries. So we have at national level, and we have mostly driving policy as well as supply chain. And here is where you'd have the Kenya Medical Supplies Agency, and we have the Ministry of Health and implementing partners. When you go to the counties, this is where we have a lot of the implementation. And what we have summarized here, the key players who make key decisions in terms of service delivery for iron-folic acid supplementation. And we see it goes all the way to the community level, and the community we interface with the households. So the summary of bottlenecks that we came up with following the activity we did is, because we were focusing more on service delivery, our bottlenecks tend to read a lot from the lowest level of implementation. That's from the community, from the health facility, community, and household. And so at household level, these are the key bottlenecks that you were able to summarize and come up with. And we found that a lot of these, actually, if you read a lot of the research done in our country about iron-folic acid supplementation, they tend to correlate. So, for example, there's a poor utilization of iron-folic acid supplements and predominantly late initiation of antenatal care. So for jumping into the implementation research, the rationale really is that we would like to integrate iron-folic acid supplementation as part of focused antenatal care. I mean, this is what the policy says, so we are going to try and make this happen. One of the other things that we've noted, and it's also in national surveys, is that less than 20% of pregnant women see K&C services during the first trimester. We tend to see great numbers towards the end of the pregnancy, predominantly the 3rd trimester. Another thing that has happened is that due to the devolution of health services, that is transfer of the mandate for service delivery to the counties, we've had a change in the way things used to operate from what we knew. And therefore, we are seeing a lot of supply chain breaks, and we would like to address some of these issues at that level. So our objectives, the general objectives really is to strengthen the knowledge base and practice for maternal nutrition, and also to increase consumption among pregnant women. The specific objectives, there are 4 of them, and they look at the targeting the mother. We are looking at working around the system, specifically on the supply chain. We're looking at working with the community health volunteers at that level to try and improve communication on maternal nutrition, and also to work with the mother so that we are able to promote early disclosure of pregnancies, subsequent initiation of focused antenatal care, and also linked to health facilities. So our intervention for this research will be focused on an integrated package. For example, mapping of households, looking at contextualized key messages for pregnant women, standard tools for use by the community health volunteers that will guide the interpersonal counseling, provision of iron-folic acid supplements at that level, at community level, use of the mother-child booklet, and also improve the requisite documentation around maternal health. We will also try and use the community outreach to address the issues of access. So after you map, you try and get the services closer to the pregnant mothers through outreach activities, and you bring in the specialists to be able to offer these services. We'll also look at working on a schedule of household visits that cover the 9 months in pregnancy and tailor the specific messages during this time. We will layer these activities on the currently baby-friendly community initiative activities that are going on. So we're implementing this in about 22 community units, and we will layer this on the 22. However, this activity, we will focus it in only 4 counties. That's Busia, Kitui, Marsabit, and Tharaka Nithi. So our study design really is a mixed method, looking at a sample size of 180 pregnant women per stadium. We will focus on getting mothers in the first and second trimesters and focus it on the 4 counties which I have just previously mentioned. So some of the lessons learned so far is that and this came out from the bottleneck assessment when you had the teams from the counties, there's a culture of evaluation and inquiry, and this is among the service providers. And while we looked at the statistics in terms of, for example, maternal mortality, uptake of ANC services, skilled birth deliveries, it was very clear that there were a lot of questions why some of these services were not being provided at the correct time. Knowledge brokering, we've also learned a lot in terms of what we were able to see as we initiated these activities. And this is a critical bit. As much as we build capacity at both levels, national county level, it's actually one of those that will foster commitment for future implementation research activities. And then implementation research really also provides an opportunity for collaboration and also program redesign by all the stakeholders concerned. So our next steps really is the presentation of this proposal to the Nutrition Research Technical Working Group. Then it makes its way to the IRB, and as that is going on, we were considering starting a desk review of the mother-child handbooks to see if they're actually being used, because this is a key tool that captures information about the mother during the 9 months of pregnancy. So I'm out of time, but just in terms of contribution, it's really the experience that has helped or will help in guiding and creating effective linkages between researchers and implementers, policymakers, donors, so that we are able to actually look at designing programs better that are focused and more objective and will provide the desired outcomes. Also, the contribution to IS is really an objective analysis and description of adaptable approaches for program design. So this activity could assist those who are interested, could be donors, it could be the government itself, to focus funding on specific areas that provide tangible return on investment. So this is my conclusion. I'm not going to read through it, but I want to thank you for your kind attention for those who logged in. Isabel, over to you.
Thank you. Thank you so much, Brian, for another great presentation. So we have a lot of questions, so I will, from the audience, I will go through this, but I wanted to also mention something important because we are presenting you those two experiences as they are taking place. And so one thing that we didn't mention is in July, last July, we had the launching of the event and the initiative in Uganda with the two teams. So it's really ongoing, and we are talking about the experience of a few components so far, but because some of the questions are talking more about like the sustainability and what were the experience, so we'll have another webinar to talk more about the results. So I'm moving to two questions I'll merge. One is from Peggy Konis-Buer and Tiana Jaramillo that are asking to Twaha in Uganda, please could you clarify how much time this process took in Uganda? And Tiana was asking about it's not clear if sustainability improvement were achieved, so the improvements are taking place. So maybe Twaha, you can say a few words when did the major event took place since the workshop in July? Over to you, Twaha.
Thank you very much, and thank you very much for the question. Like you alluded to, it's not clear how much time that the person is asking about, but in terms of how much time we've taken so far since July last year, I think we did our first initial activity of the Bottleneck assessment in October last year, that's 2018. And it was a 2 days workshop. So from that, we've been able to actually continue doing other activities like the district validation and the other things of developing the protocol and all this. So really, like I said, the time has not been documented in terms of assessing sustainability. But I think that, like Isabel was saying, this is already still an ongoing initiative. So we are still under the process of implementing the initiative. I hope that addresses the question. Thank you.
Thank you, Twaha. Maybe I'll just add is in October, Twaha, like in Uganda, they had their bottleneck assessment. So it was a main achievement. Then they wrote the report, and it took a few months to try to read some of the literature based on the bottleneck that they had identified. So I support them, but they developed their own protocol that was just reviewed by their IRB. And so we're still in the process of doing this. What they are already taking place is the quality improvements. So there is another question that I will go after, but I'd like to ask a question, maybe this time that is coming from Amanda Wendt. Are the supply issues uncovered, for example, annual purchasing leading to under or over projection and regular stockout in case of under projection happening for other drugs in addition to IFA? So maybe I just want to mention that we have looked a lot about your work in BR, Amanda, and so we're trying really to build on what has been happening in other countries as well, using those questionnaire. And so I think a lot of the things came out from the bottleneck assessment. It has not been investigated to the level of the implementation research. But do you want to talk a little bit about that, Brian? If you were able to uncover problems with other drugs as well, and not only IFAS.
Thank you, Isabel and Amanda, for the question. I think the problem for us really is the supply chain issues. For example, you have very strong programs, and I'll use an example of the HIV care and treatment program. So that program has strengthened the supply chain across, and you tend to see supply chain for those commodities, working very well. Now, for commodities, for example, and IFAS, the iron-folic acid supplements, we still have a break in supply chain, especially here because they were considered. It was considered, or decisions were made that counties were able to purchase this, so they are not under the national, what I would call in terms of, for example, national programs like HIV. So these were given to the counties. Now, for counties to determine whether this is relevant or not, as much as they're not that expensive. It's purely an issue of a lot of sensitization and advocacy on the importance of iron folic acid supplementation. So maybe to answer the question, I hope is that there are some commodities where you don't see supply chain breaks and they're very well managed, but on others, especially these, they're not very high value. You see a lot of issues around supply chain.
Thank you, Brian. I have another question that may be addressed by both. So I'll start with Twaha. It's coming from Rasmi Avula. So were there any power dynamics during the workshop as a very diverse group of participants came together? If yes, then how were they managed? And so I will give the speech to both of them because they had different participants and different experience. So do you want to comment over the power dynamics potentially, Twaha?
Thank you, Isabel. Well, in terms of, because there were more of multi-dimensional stakeholders in the meeting, I would not say that there were lots of power dynamics because first of all, the purpose and the objective of the workshop was very clear in terms of actually identifying bottlenecks. However, the issues that were actually highlighted were issues of having disconnect between the national level stakeholders and the actual implementers at the health facility levels. For example, the National Medical Store was claiming or saying that they have the stocks of iron-folic acid, but then the health workers at the facility level or from the facilities are actually saying we have issues of stockouts. So there was just that disconnect between in terms of experience. But one of the things that actually we learned is having to bring these groups together in a room and being able to discuss the same issue actually helps to map out the issues within the system, because you're able to identify these disconnects and then find ways of how best to address them. So I can't say there were really huge power dynamics in terms of people having to show that this is the right thing or this is the wrong thing, but rather a concerted effort and having to work as teams to actually identify system issues. Thank you.
Thank you very much, Twaha. Now I will leave to Brian to maybe comment a little bit about those power dynamics. Up to you, Brian.
Okay, thank you, Isabel and Rasmi, for the question. Yes, we did have power dynamics, but not to a great extent because of the diversity of the participants, where we got more or less from the national level. We had the core team, and then we mixed at county level. And the county level also, we have key decision makers in terms of the health managers, and then you go and get the implementers from the sub-county level or districts, and lastly from the lowest level at community level. So because of the mix, I think the power dynamics, just like Uganda came when you discuss supply chain issues, but at each level they were able to provide the perspective of the issue. And because of the structure of the workshop, in terms of norms, we agreed that everybody is given an equal opportunity, plus you can say anything and it won't be taken personally. So I think we created a culture of openness, and a lot of the issues that came out were more seen from a perspective of trying to make the system better or improve service delivery. So maybe not to a great extent, but yes, they were there, especially where you have national and county. It's going to be a natural occurrence. Thank you.
Thank you very much, Brian. We have a few minutes left, so I'm going to go over a few more questions. One is from Justin Cable. What is the source of this data? Is this national or subnational data? From which countries? And so I think you were referring to Kenya. And so, because I just want to add a few words, in Kenya, they are still developing. They have not submitted yet their research proposal, so it's still in process, but the data will be collected eventually. And the data are collected at various levels. What I intend to do, because I know your work on baby-friendly community initiative, and Brian is really, they're trying to build on this platform. So I'd like to just to merge a little bit these questions is, Brian, could you talk a little bit about how like the baby-friendly community initiative will be used as a platform to not only collect the data, but do the intervention in Kenya?
Well, thank you, Isabel and Justin, for the question. So if the question is where will the source of data come from, the source of data will actually be at subnational data, which will come from community units within the counties. So if that's what the question is about. But over to baby-friendly community initiative. Yes, we're going to layer this activity on the baby-friendly community initiative based on the investments we have made in these counties. So, for example, because of the network of community health volunteers we have, those whom we have trained, and the activities they're actually doing on baby-friendly community initiative, just as for those who may not be familiar with the baby-friendly community initiative, it's actually taking the 10 steps and working in the community. 10 steps of infant and young child feeding, and trying to make them work in the community. So we have a national guideline for this in Kenya, and it's recommended or implemented within the community level. So the focus for this activity, baby-friendly community initiative, looks at there's an aspect of maternal nutrition that's not so strong, but there's a lot of focus on the aspects of infant and young child feeding from birth all the way to 11.9 months. So what we've done is, when we layer this activity, we are going to look at how we can strengthen the component of maternal nutrition, and all, for example, the intervention package we have talked about will be built into the already existing infrastructure for baby-friendly community initiative. So I hope that provides some insights, and also that I was able to answer Justin's question.
Thank you, Brian. We could talk for a long time about those things, but we're trying just to cover a few points. One question for you, Tuaa, it's coming from Ed Frangillo. So could you please comment on what you found to be the strengths and weaknesses of the bottleneck assessment in understanding the implementation issues? The strengths and weaknesses of the bottleneck assessment. If you can say a couple of words on this, Tuaa.
Thank you very much. I will start with the strengths of conducting the bottleneck assessment. One, I think, and majorly, is the fact that it gives an opportunity to the different stakeholders to be able to discuss the same idea, or to sit down and discuss the same agenda. For example, the fact that most times when you look at the way things are done, you'll find that we have national level policies that are pushed down to the facilities to implement. But the bottleneck assessment was able to actually bring the policymakers and then bring the implementers together in a room and be able to discuss and identify the actual issues that actually are affecting service delivery. So you have more of an experience-based input from the implementers, and then of course from the other side. That is the major strength, I would say, from the bottleneck assessment workshop. Then in terms of the weakness during the conducting of the bottleneck assessment, of course, one of the key things, and I think this was something that was from the side, was the fact that the bottleneck workshop did not actually look at site specific in terms of performance, in terms of data. For example, I can't say that we looked at the data from the facilities in terms of performance. So we didn't have much use of data, but was majorly from experiences and from views of the different people and literature that is available within the country. Yeah, thank you.
Thank you very much, Twaha. We're reaching the end of the webinar. I will take only one question, which is to end before ending the webinar. This is coming from Nathan Tumwesi, who is the chief of party of the URC team. And so Nathan is wondering, so for Brian, the geographic reach for the Kenya study seems to be rather large, having 4 counties, considering the small sample size, plus the rather heavy capital-intensive community harm. How will you manage that within the size of funding and limited time? So I think we had a lot of discussions over like the scope of the implementation research, because the counties can be large. So I don't know if you want to say a few words on this, Brian, how you think you'll manage. I know you have a big system to be also collecting data.
Thank you, Nathan. So the 4 counties, first and foremost, reflects what we would call in terms of geographic dispersion, ecological zones of this country. They happen to be the same counties where we work in. There are also counties where USAID has made significant investments, not just in this program, also in other programs, specifically maternal child health. So in terms of that, you do find that the health infrastructure, even at community level, does exist, and it requires facilitation to make it work. So because that has already been done, we are layering these activities on that. And that's why when I started, I talked about this being a co-creation activity. Also within the counties themselves, because of the devolution of health services, there's also resources, not as much as we would like, but there are also resources at that level that the county will make available. For example, in some counties, they do pay stipends for community health workers. So this comes from the county exchequer directly to the community health volunteers. So what happens is we are basically going into a system that has been somewhat resourced, and we are trying to make this work. So about the sample size, you will agree that it's quite difficult to try and get pregnant women, especially in some of these counties. Marsabit is an arid, semi-arid region. So that explains some of the reasons behind the sampling. And there's still a lot of discussion in terms of the rationalization of the sampling and what the frame will look like. That maybe I think we can reach out to me and we can discuss more. But I hope I have provided a glimpse in terms of some answers to your question.
Thank you so much, Brian. Thank you so much also, Twaha, for responding to the questions, and for the audience to share so many thoughtful questions. I was unable to ask them all, but if you want to get in touch with us, you can contact the society, and we can follow with you at the info@implementnutrition.com. There was one question from Dr. Gomati from India. We couldn't touch about the community level bodies, if there would be some involved, and I just want to reassure you that we're really trying to work also with the community level, because women do not attend ANC, so I think it's important. We're really trying to take a systematic and systemic approach. So we hope that this webinar has been informative and thought-provoking. If you have questions, as I mentioned, you can communicate with us. You can visit our website to stay in touch with the society's activities and learn more about the implementation science in nutrition and various engagements. SISN is also active on social media and welcome your thoughts, comments, and engagement through our Twitter and LinkedIn page. Once you leave this seminar today, you will receive a very brief survey on the webinar. And so we would appreciate if you would take a few moments to provide your feedback. You will also receive a follow-up email in a few weeks with a link to today's webinar recording in the URL and the PDF of this slide. So on behalf of SISN and our presenters, thank you so much for joining us today, and I wish you a great end of the day. Thank you very much.